Thank you for the opportunity to present. My name is Travis Miller, and I'll be presenting our research regarding antibiotic prophylaxis and implant-based breast reconstruction using acellular dermal matrix. Tissue expander infection can have significant impact on patients undergoing breast reconstruction. Patient-reported outcomes suffer for patients who have infections as part of their treatment course, and the estimated extra cost of an infection in these types of cases is in excess of $12,000. Beta-Lactam antibiotics are standard surgical prophylaxis for implant reconstruction cases as recommended by the ASPS, though any recording of a penicillin allergy often causes patients to be switched to non-penicillin and non-cephalosporin antibiotics, such as vancomycin or clindamycin. However, it is key to note that many of these alternative antibiotics are bacteriostatic in nature, while beta-lactams are bactericidal. Thus, these alternative antibiotics may theoretically be less effective. We thus hypothesized that patients who received bacteriostatic antibiotics for prophylaxis for implant-based breast reconstruction would have a higher infection rate than patients who received bactericidal antibiotics. We thus undertook a single-center prospective analysis examining patients who underwent immediate implant-based breast reconstruction with acellular dermal matrix. Our analysis included 320 patients. Input variables of interest included comorbidities, the type of mastectomy performed, the use of perioperative chemoradiation, and type of antibiotic prophylaxis. Prophylaxis in these cases included dosing prior to incision, intraoperative redosing as appropriate, and antibiotics given in-house prior to discharge. Our outcome variables of interest included any infection that required treatment, major infections that required operative drainage, and reconstructive failures that required implant removal. Some of our demographic results can be seen here. Our patients had a mean age of around 48 years and an average BMI of 25. Average follow-up was around 15 months, and around a third of patients received either chemotherapy or radiotherapy in the perioperative period. The majority of mastectomies performed were nipple-sparing, and most were done for a cancer indication, though a small portion were purely prophylactic. From our patient cohort, we recorded which patients had allergies listed in their medical record. Notably, about a fifth of patients had some sort of beta-lactam allergy reported, with a large portion of these being a reaction to penicillins. Most of these reactions, over 70%, were relatively minor reactions including rashes or nausea, but recording of an allergy often meant that a beta-lactam was not selected for prophylaxis. The actual rates of antibiotics given can be seen here, and about 15% of patients did not receive a beta-lactam antibiotic, with clindamycin being the dominant alternative. Notably, around 95% of patients received additional antibiotics after discharge with a home oral regimen, which was usually the same class as the preoperative antibiotic. The overall complication rate was around 37%. 20% of patients had an infection that required either inpatient or outpatient antibiotics, 6.9% of patients had infections that required surgical intervention, and 10% of our patients experienced loss of the prosthetic with ultimate reconstructive failure. We performed univariate analysis to look for potential risk factors for infection, and notably receiving a beta-lactam antibiotic was protective against infections. We then analyzed the same variables for major infections, which were defined as infections that required operative intervention to achieve resolution. Again, the use of beta-lactams was protective against this outcome. Thus, it can be concluded not only does receiving an alternative antibiotic predispose these patients to infections, but their infections are also more serious. Finally, we analyze the outcome of reconstructive failure against these risk factors. And again, receiving a beta-lactam for prophylaxis was protective against implant loss. Notably, receiving a post-operative antibiotic of any sort after discharge, beta-lactam or not, did not prevent infections or affect the rate of implant loss in this cohort. Thus, in conclusion, bactericidal antibiotics are superior to bacteriostatic alternatives in preventing infection for implant-based immediate breast reconstruction with the use of acellular dermal matrix. It may be worth giving test doses of beta-lactams or performing desensitization protocols in patients that have previously recorded allergies so that they may receive the most potent prophylaxis available. In addition, post-discharge antibiotic prophylaxis does not appear to be protective against infectious complications, and this practice should be discouraged. Thank you.